Great. Good afternoon and welcome to the first live streamed meeting of the Leeds Health and Wellbeing Board. My name is Councillor Rebecca Charlwood. I'm Chair of the Leeds Health and Wellbeing Board. I'm just going to remind members to turn their microphone to mute when they're not speaking. Use the hand, and go in the chat to indicate if you would like to speak so we can move through the agenda. I'm going to ask all members to introduce themselves in turn, and I'll just take people as I can see them on my screen. So if I could ask Jason Brock.
Good morning, I'm Jason Brock. I'm a GP and I'm clinical chair of NHS Leeds CCG.
Thank you. Tim Riley.
Hi, Tim Riley, Chief Exec at Leeds CCG.
Thank you. And Hannah from Health Watch.
Good morning, I'm Hannah Davies. I'm Chief Exec at Health Watch Leeds.
Harriet Spate.
Good morning, Harriet Spate, Governance Officer, Leeds City Council.
Thank you. Victoria Eaton.
Hi, I'm Victoria Eaton, Director of Public Health at Leeds City Council.
Thank you. Julian Hartley.
Good morning, I'm Julian Hartley, I'm Chief Executive of Leeds Teaching Hospitals.
Thank you. And Lou, is it Olga?
That's correct. I'm Lou Auger. I'm Deputy Locality Director for NHS E&I in West Yorkshire and Harrogate, here on behalf of Anthony Keeley today.
Thank you very much. You're very welcome. And I should have said, if anyone is deputising, could you mention the person you're deputising for? That would be great. Thank you very much, Lou. Anthony? Thank you. And Lou, is it Olga?
That's correct. I'm Lou Auger.
Anthony?
Yeah, it comes up as Anthony. It's Tony Cook, Chief Officer Health Partnerships. Thank you.
Thank you. And Sarah Munro?
Hi, Sarah Munro, Chief Exec, Leeds and York Partnership, NHS Trust.
Great, thank you. Alistair Walling?
Hi, it's Alistair Walling, GP and Chief Clinical Information Officer for the Leeds City and CCG.
Lovely, thank you very much. And Councillor Norma Harrington?
Hi, Weatherby Ward, and I'm substituting for Councillor Latty this afternoon.
Thank you. Kath Roth.
Good morning, Kath Roth, Director of Adults and Health for Leeds City Council.
Thank you. Fiona Venner, which is Councillor Venner.
Thank you. Good morning, everyone. I'm Councillor Fiona Venner. I represent Kirkstall in West Leeds, and I'm the Executive Board Member for Children and Families. Thank you.
Great, thank you. John Beale.
Good morning, John Beale, and I chair Health Watch Leeds.
Thank you. Gaynor Connor.
Good morning, everybody. I'm Gaynor Connor, Director of Transformation for Leeds GP Confederation, and here this morning on behalf of Jim Barwick, Chief Exec of the Leeds GP Confed.
Great, thank you. And Chris Dickinson.
Hi, I'm Chris Dickinson. I'm Head of Commissioning at Children and Families at Leeds City Council, and I'm here on behalf of Sal Tariq, Director of Children and Families.
Thank you. Councillor Galton.
Hi, Councillor Galton from Rothwell Ward and Liberal Democrat Rep.
Great, thank you. And Alison Lowe.
Hello, I'm Alison Lowe. I'm Chief Exec of the Third Sector organisation in Leeds, and I'm here to represent the Third Sector for Forum Central.
Thank you. And Paul Bollum.
Hello, my name is Paul Bollum. I'm Head of Leeds Plan.
Great. Jane Mishenko.
Hello, I'm Jane Mishenko, Strategic Lead Commissioner for Children and Maternity at the CCG, here for a specific item.
Thank you. Sue Gibson.
Good morning, I'm Sue Gibson, Director of Midwifery at Leeds Teaching Hospitals, and I'm here with Jane to present an item shortly.
Thank you. Arfan Hussain.
Senior Governance and Partnerships Officer, Health Partnerships Team.
Thank you. Gina Davey.
Hi, I'm Head of System Integration at the CCG and here for the item on integration, and towards the end of the meeting, deputising for Jason and Tim.
Excellent, thank you very much. And Simon Hodgson.
Yeah, good morning, everybody. Simon Hodgson here, Head of Service for Safer Leeds, deputising for Paul Money. Thank you.
And I've also got Rob McHugh.
Hi, Rob McHugh, Senior Support Officer.
Thank you. And Thea Stein.
Hi, I'm Thea. I'm Chief Executive Leeds Community Healthcare Trust, and I can't get connection on my computer, so I'm just holding my phone up at the moment, which is why I will not be on video for very much, because I can't hold my phone like this the whole time.
No, that's fair enough. And if anyone has any connection issues, yeah, you know, this sort of thing happens, doesn't it? So that's fine, and thank you. Holly.
Morning, I'm Holly Danhauser. I'm Partnerships Development Manager on behalf of the organisations represented on this board.
And I've got an LCC laptop, so I'm not sure who that is.
That's also me.
That's you as well. You've got two. Excellent. Very good. Manraj.
Manraj Kayla, Head of Partnerships.
Okay, great. And Debbie Oldham. Debbie?
Debbie's just looking after the webcast for us today, Chair, so she might not be.
That's great. So anybody who's watching has now been introduced to everybody who you can see on the screen, and it's really important that people know who people are. As you can see, it's a very wide range of stakeholders from right across the city in our health and care system. So very welcome today. Thank you for coming. Right, so some housekeeping. So please make sure your Zoom username is the same as your actual name. Please turn on your videos if you can, but if you're having connection issues, it can help to turn off your video. If you're having any technical issues, it sometimes helps to leave and rejoin the call. You can contact by directly messaging Arfan Hussain in the Health Partnerships team if you're having issues with connections or any issues with the meeting, and he will try and help you. Also, if you're watching on YouTube, please do ask questions, and we'll try to bring in relevant questions if we can, but we do have a very big and packed agenda. But it would be really interesting to hear what people are thinking. So just a bit of a preamble on the current situation that we're all facing. On behalf of the Health and Wellbeing Board, we would all really like to thank everyone in Leeds who's doing so much work to respond to the COVID-19 crisis. The virus is impacting on a large part of our city, all over our city, in pockets, and the impact of it's going to be felt for some time on health, but also on issues around economy and well-being. And we really want to work as a board to try to support people to have healthier lives and live in communities which are healthy and support well-being. And that's one of the purposes of the Health and Wellbeing Board, is to support people to live in a healthier city and not just provide health services. But we have, a key role now more than ever to respond in a strategic way to the crisis that we're facing and the issues that we're facing as a country. So how we structure and deliver our services to be representative of the diversity of our city and make progress on our vision of improving the health of the poorest the fastest is more important than ever. So the strength of our relationships and our ways of working as team leads has kept us connected and helped us respond really quickly and effectively. And it's really important to keep doing that. And I want to thank all the members of the board for their teams and all the work they're doing. I know people are working night and day to respond to this issue. I would really like to take the opportunity as well to congratulate and welcome Dr. Jason Brock as the new clinical chair for NHS Leeds CCG. He's replacing Dr. Gordon Sinclair, who retired earlier this year. Jason's, of course, no stranger to the Health and Wellbeing Board. His amazing knowledge of Leeds, the health and care system, and his passion for improving the health and well-being of people is exactly the type of person we need, and it's wonderful to have him back on the Health and Wellbeing Board. So I'm just going to go through the formal items on the agenda, which is the bits we have to do for formal recording purposes. So I'm going to ask Harriet to respond to me on these. Is there any appeals?
No appeals, Chair.
Are there any exempt information?
No exempt items, Chair.
Any late items?
No late items.
Any declarations from the board of disclosable pecuniary interests, that is a financial interest that directly affects you or your partner? Relevant on the agenda today? No. Okay. Any apologies?
Yes, Chair. We've received apologies today from Councillor Latty, Jim Barrick, Anthony Keeley, Paul Money and Superintendent Jackie Marsh. And as have already been mentioned, we have Councillor Harrington, Gaynor Connor, Lou Olga, Simon Hodgson and Gina Davey here today as substitutes.
Thank you. And thank you for those substituting for people who couldn't make it here today. They've introduced themselves. Thank you for that. Okay, do we have any questions and public deputations? Item 7.
Thanks, Chair. We have one question that's come in, an excellent question actually, from Dr. Ruth Gilletley of Living Streets, Leeds. Living Streets Leeds campaign for livable and walking environments across the city and elsewhere. And the question, it's quite a long one, but I will read it. It's an excellent question actually. It's how will the NHS work with partners to support measures to increase physical activity among the communities they serve in the proposed active travel neighbourhoods? Now, these are proposed neighbourhoods in Hyde Park, Holbeck, Lincoln Green, Chapeltown, Beeston and Otley. And the aim is in those neighbourhoods to make more space for walking and cycling by closing roads and promoting active travel. And the question outlines the strength of the evidence base for walking, cycling and active travel, particularly in and around tackling certain diseases, CVD, diabetes, many cancers, etc., etc. So the question is specifically to NHS colleagues. So I'm going to ask probably Jason, Julian, Sarah, Thea and Tim, if any of them would like to come in and comment about how they can work in partnership with local government and the third sector to promote active travel ultimately.
Okay, so I can't see everyone on my screen all at once. So if somebody who would like to go first. Julian, do you want to go first?
Yeah, happy to do that. Really important. Thanks for reading out the question, Tony, and thank you to the questioner. We've got, together with our partners across the NHS in Leeds, I think for all of us, a very clear ambition about health and well-being of obviously our staff, but also of the wider population. And a lot of that manifests itself in the work we do collectively as anchor institutions in Leeds on the health and well-being strategy, but also in our own plans. And certainly here in Leeds Teaching Hospitals, we have got, as part of our own health and wellbeing strategy, a lot of work that we do both internally with our staff in relation to fitness and health, but also crucially with local communities. You mentioned in the question the community of Lincoln Green. That's a particular area for us right on our doorstep where we're working with the local community. A lot of that is about development of health awareness and education, and a key part of that is fitness and health. We're also working more broadly across the city with the promotion of greener travel options, cycle lanes. We're already seeing the development of cycle lanes. We've been working with the City Council for healthier transport and cycle lanes that connect our hospitals. So there's a lot of work going on, and I think we're always keen to connect with partners. So I'll be grateful to make sure that we're connecting our work to those of the points raised in the question.
Okay, thank you. Do any other partners wish to comment? Sarah?
Yeah, thank you. And echo a lot of what Julian's already said, and just additional response really. There's two approaches to this. One is the work that we do with our staff in terms of their health and well-being, encouraging greener forms of travel, as Julian described with his organisation, through a range of different schemes. But there's also some really important work that we do with our service users who have got serious mental health problems and have got learning disabilities, and that's through teams that we've now got in place that really do focus on health facilitation, improving physical activity and looking at that holistically, and those operate in the community, so targeted, like I say, within our learning disability services and in our mental health services. And we also have the same in Becklin, where people work alongside our service users to get out and about and understand how they can live a more active lifestyle. And a lot of that in the community is done in collaboration with our third sector organisations, who we know do actually a lot more than we do, direct into local communities to those that use our services on that more holistic wellbeing.
Okay, thank you very much. I have Victoria Eaton who'd like to comment.
Yes, thanks, Councillor Charlwood. Just to add a couple of very specific things to what colleagues have already talked about. Obviously, as a public health function, we work right across the city, including closely with our NHS colleagues. So just to mention a couple of key things, that this week we've gone live with a new referral system from GP practices to a whole range of healthy living services, and within that it's the first time that GPs can refer to active Leeds, which supports people in a whole range of physical activity opportunities, including walking and green travel. So that's something that's new and has happened within the last week, which is a really positive development. I think the other specific thing to say is that we run something called physical activity clinical champions training for clinicians across primary care and secondary care who are interested in supporting people to be more physically active. So this has just started, but already we've got 55 clinical champions across the city who have taken on this role, and that work will continue. So they're just a couple of examples of the things that are in place. Thanks.
Thank you very much. So we've got some really strong responses from right across the sector and the city today. I've got Dr. John Beale who'd like to speak. Is it on this issue?
Yes, Chairman, although it's not specifically about the NHS, but more widely, because I think that in many cases it's become the social norm to jump into your car and drive wherever you're going, even if it's on fairly short journeys. And social norms are learnt early in life. And anyone who lives near a school will see the very high proportion of kids who actually are driven to school, irrespective of how far away they live. So particularly perhaps in the active travel neighbourhoods, but also more widely, I think work needs to be done to encourage schools to themselves encourage parents not to drive their children to school if there's any possibility of them walking or coming by bicycle.
Yeah. Thank you very much, Dr. Beale. That's very helpful as well. And I can't see any more indications of people who would like to speak on this. Oh, I have now. Hannah, would you like to say something?
Sorry, yeah, just to say, I think it's also got a sort of, particularly in light of COVID and moving into the winter, we're hearing from a lot of people in terms of, and we know that, people won't be able to get out as much, and the impact that will have on sort of social isolation, particularly around older people. So I'd be interested to think as a city how we considering that people can be active and get out and walk and also be active within their own homes as well during winter. It feels like two of the key things that we need to consider is how can people be active and how can people connect over the winter in what could be a very dark and difficult winter period.
Yep, absolutely. I think the issues around winter and the restrictions that are being placed upon individuals is something really important that we have to consider, and I think we all want to try and get our heads together about the sorts of something we can offer the city around that, not least about physical exercise, as it is hard to get out when it's cold and raining and snowing and all of those things as well. Okay. Are we happy to move on at this point? Thank you. I've not received any indications of any live questions that have come in yet from the YouTube forum. So I think we'll move on if that's okay. If there's anything that comes up later, we may find a way of putting it in, trying to be as open to the public as possible. Okay, thank you. So we'll go to minutes. That's item 8. Can we agree the minutes from the 20th of February meeting as a true record? If anybody who doesn't agree, could they pop it in the chat and I can bring you in? I'm happy to accept those as a true record. I can't see any indications. Thank you. Right, so we're going to go on to one of our main items, which is item 9. And for the public's benefit, we had a private session at the beginning where we heard some incredible personal stories about people's experience of using maternity services from Black, Asian and minority ethnic backgrounds. And it's really important as a board that we hear the voice of the public and the service user and people who have strong experiences within our system, so that whatever discussions we have and decisions we make as a system, we can root that in personal experience and what's important to people, rather than something about buildings or something less personal. So that was a really useful session. I'd just like to thank all of those who took the time to give us their personal experiences. It is a gift to us that they have given their time and energy, and in many cases emotional energy as well. So I really, really thank them for that. So I'm going to hand over to Jane Mishenko and Sue Gibson, who can speak to this item. Thank you.
Okay, great. Thank you, Chair. It's Jane Mishenko here, and I'm going to start off before passing on to Sue. So if we just go to the first slide, Arfan, please. Okay, so the item we're here to discuss today is a refresh of our maternity strategy. So we've had one for 5 years. This is our final year of the first one, but we need to refresh that. There's lots more that we want to do and need to do. So it's a really exciting time. We have achieved a lot in the last 5 years, but we do recognise there is more to do as will unfold. So I just want to say that we have a real strength in our city in the maternity services, and it's a key arm of our very excellent integrated work that we do across the partnership, which includes public health, health visitors, children's centres, the third sector and perinatal mental health services. It's a key contribution to giving the best possible start for every baby in Leeds. You'll have seen from the supporting paper that the way we've drafted our priorities for the next 5 years, strongly informed by local population data from our health needs assessment, from insight that's come from women's and families' voices about what matters to them. And I'm going to pass to Sue for the next couple of slides, just to really show some of the strengths and opportunities that we have.
Thanks, Jane. So we have an annual national maternity survey, and Leeds has been rated amongst the top 5 for staff kindness, patient experience and overall quality of care in the last 2 years, and we're incredibly proud of that. But we can't be complacent. It's really powerful that the survey is gathered directly from local women who have used the service. And it's the comments that they say that we need to take note of, listen to them. Progress made is reassuring, as a survey does ask women across all aspects of pregnancy, birth and afterwards. And our current Leeds maternity strategy has certainly supported our progress alongside the collaborative integrated approach that is such a strength in Leeds. Choice and personalisation alongside improved outcomes is vital, as much as possible, to ensure the uniqueness and embrace the experience for each woman and her family's experience. But as Jane and I have both said, we can't be complacent with this success. We're only as good as today. We want to strive and move forward, and we need to address the inequalities that do exist across our very diverse communities. We need to understand our data and strive for those improvements in outcomes and in overall patient experience. Next slide, please, Arfan. So one of the really exciting things to consider for the next 5 years in our strategy is the maternity service reconfiguration. Colleagues will know that following public consultation in July, our Commissioner supported the reconfiguration of our hospital maternity services into one of the new hospitals. This should be completed within the timescale of the refreshed maternity strategy. So we're really keen that this is an area of service development that's integral to our strategy. There's a real opportunity to maximise the quality and safety of our service and our workforce, as well as have an estate that is fit for service and enhances the experience of Leeds women and their families, and obviously wider as we are a tertiary unit. 70% of our antenatal contacts are currently in the community, and we've got an ambition to increase those contacts. In addition to the centralisation of hospital services, we're committed to establishing an integrated community hub near the St James's site to support improved access, experience and outcomes for communities who live in this area. And I'm now going to move on to Jane. Next slide, please.
So we promised that we're going to be quick, so that there's plenty of time for the conversation. So I've just got a couple of slides here that just bring out a couple of key points that kind of underline the health inequalities we have in the city, and how also that relates also to deprivation in terms of we have a third of our births, you know, there's 10,000 births a year and a third of those are born into deprived Leeds. And we have an increased proportion of births to Black, Asian and minority ethnic women since 2001. They're overrepresented in deprived Leeds with poorer access and outcomes. So we absolutely have to have this as a priority. We've got an increase in infant mortality and a consistent gap between deprived Leeds. And there's increased complexity of health and social factors. And if we move on to the next slide, there's some recommendations that's come out of the maternity health needs assessment. And I'd just like to thank Nicola Goldsborough, who's supported us in doing the maternity health needs assessment. It's an 80-page document, which is absolutely fantastic resource to help us as a partnership develop our strategy. So I just wanted to note that. And the last point, just to flag that, data collection, reporting and sharing needs to be more robust. It's improved since last time, but it needs to get better. Okay, just moving on. And so these are the draft priorities that have been drawn from the data, the conversations, and the very many routes of engagement that we have done. Not least, there were more than 1,500 people responded to the formal public consultation that we had to do about the reconfiguration. But prior to that, in the creation of our initial strategy, every time we created a pathway or developed a new service, we engaged and co-produced that service with women and families. And we don't just use digital surveys, we work with the third sector to reach out and hear all voices. So I don't think there'll be any surprises. We think reconfiguration absolutely needs to be a priority. It needs to be central, not running in parallel, as well as the exciting opportunity for local families to be engaged in the clinical design of the hospital maternity services. There is tremendous opportunity to really get our community services working effectively, and particularly to explore that community hub creation in the site near St James's. And we probably need some help from the health and wellbeing data, and it being more than a maternity hub. I think it should be an integrated hub. Hopefully you can all hear me. My computer's telling me my connection's unstable. Okay, so if we just move on. So just as Councillor Charwood mentioned, prior to starting the formal group, we had breakout groups. We heard directly from people representing Black and Asian communities about the experiences of their communities in relation to maternity services. And certainly the group I was in was so powerful and has provided so much food for thought. And just to remind Health and Wellbeing Board members that these are the things that we asked you to bring back for the discussion that's going to take place now.
Okay, thank you. Have you both concluded your opening remarks for this item? Yeah, and I can't see any indications that somebody else needs to speak. I've got a couple of people who've highlighted questions. I think I've got Julian, and then I've got Julian Hartley, and then I've got Councillor Benham, if that's correct. Please go ahead if you want to ask.
Thank you very much. Thank you very much, Chair. Can I just, first of all, I think, pay tribute to Jane and Sue, the work, and the whole team indeed, the work that you've done on this, and particularly in relation to obviously the lot of work on the maternity reconfiguration and the consultation. It was, I think, indicative of the quality of the work that's gone into it, that when we attended the scrutiny board. Councillor Hayden, who chairs the scrutiny board, paid tribute to the very engaging and positive way in which consultation had taken place and described it as an exemplar. So that's good in terms of the way that the team have engaged colleagues, and I know I've been involved in some of those meetings with a whole range of participants and stakeholders. The point I wanted to make and the question I wanted to ask was, I was really struck by the Thelma's points in our session about the experience and indeed education of a number of our Black, Asian and minority ethnic communities and parents. And I noticed that in one of the key areas of focus in preparation for parenthood is better parent education. That seemed to be a key issue in relation to what Thelma was describing in her experience and her role. And I just wondered how we as a system, we as a board, and indeed through the various vehicles we've got, like the Health and Care Academy and other system-wide interventions, that we can help drive and support better parent education in its broadest sense across some of our most deprived communities, and with a particular focus on Black, Asian and minority ethnic communities.
Yeah, thank you, Julian. I think we had we distilled some things down around some people who had moved to the city from abroad, and different cultures that perhaps had different levels of understanding around biology and basic ideas around reproduction and things like that. So it's addressing some real knowledge gaps, as you say, and ways for people to keep themselves well, and how we address that. I don't know if anybody would like to consider how to pick that up, and I can go to Councillor Bennett, and then perhaps somebody could respond to that point. Councillor Bennett.
Well, thank you, Chair. I wanted to ask a specific question about fetal alcohol syndrome, which is something I've been reading a lot about recently, but also I've met a number of adoptive and foster families with children who have fetal alcohol syndrome, where the child has fetal alcohol syndrome. And I feel this is an issue that's doesn't have the prominence that it should have in terms of the prevalence of the number of babies that are born with fetal alcohol syndrome, and just the profound damage that causes. I met a gorgeous little boy pre-lockdown who had heart surgery as a baby and had really significant learning disabilities, and I think the physical disabilities and health conditions and cognitive impairment, for want of a better word, are really profound when children are born with fetal alcohol syndrome. But there's also a significant issue where families sometimes struggle to get a diagnosis, which makes a difference to the support that they can access. So I just wondered if someone could comment on that, really, because I feel that, I know this crosses into public health as well, but I feel as a city, we need a strategy with regard to both the damage, the public awareness around the profound damage that alcohol causes during pregnancy, but also the issue around the need for early detection and earlier diagnosis. Thank you.
Oh, thank you very much, Councillor Bennett. I'll also ask somebody to consider how they can respond to that, and we'll bring you in after John Beale.
Thanks, Chair. We had a very useful presentation from Heather, who talked about why some groups don't present early for maternity care in the first trimester, why they may adopt specific practices during pregnancy and during childbirth. But two specific points that came out. One is a general point that we tend to use BAME, Black, Asian and minority ethnic, as if they are a homogeneous group, and they're not. They are a very diverse group. They include, for instance, Black Caribbean, Black African, even within South Asian, there are Indian, Bangladeshi, Pakistani people from different heritage who may have very different health beliefs, very different health behaviors, and we do need to break it down and not just refer to BAME communities. So that's the first general point. The second was, as far as the maternity services are concerned, there's been a very extensive consultation, but there are some groups, and I'm not quite sure how much has been heard from these groups, that there are some groups who don't fill up surveys, they don't go to public meetings, and we do need to identify those groups and find out how we can involve them in the consultation. We probably need to meet them on their own ground, whether that's their local community centres, maybe their places of worship, but not expecting them necessarily to join in the general consultation. We may need to make special effort to hear what those communities have to say.
Thank you, Dr. Bale. That's yeah, very useful contribution. Thank you for that. I've got Victoria Eaton, who'd like to come in.
Thanks, Chair. Yeah, yes, it was just to pick up on a couple of comments relating to what Julian said, and also just in terms of Jane and Sue's presentation, I'd also like to pay tribute to the work and how they've described the approach, which is absolutely one that's been integrated across services, but also taken that broader population approach. And we've worked, I think it's an exemplar of how we should work more broadly around integration. I think it then plays into some of the comments around the issues that have just been discussed, and particularly the part around the preparing for parenthood bit of one of Jane's slides, which does cover some of the issues around addressing you know, drug and alcohol use in pregnancy or healthy living more generally. But it's one part of a broader approach that does address a whole range of other things that go beyond that programme. So the Best Start programme that we as a city support, which starts in conception for the first 1,001 days, is absolutely key in terms of improving outcomes. And Jane also mentioned the increase in infant mortality, which is really concerning for a city that was going in the right direction for many years around infant mortality, which has started to head in the wrong direction. We've recently highlighted that this is one of the 4 reasons why we're seeing the widening of the gap in health inequalities across the whole age range. We know what works around reducing infant mortality, and we've had some fantastic, very localized programs of work in communities where we've got our highest rates. But it goes beyond the healthy lifestyle agenda into the agenda of overcrowded housing, people with drug and alcohol dependency issues, all of the broader inequalities conversations that we're having around COVID in those communities that are most at risk. Many of those factors also play into these outcomes. So I would just emphasize the strength of what's in there already, but also emphasize that it does go beyond that, and we need to describe the whole of that. Part of that links to Councillor Venner's question about fetal alcohol syndrome, because one of the worrying trends is that we have seen an increase in fetal alcohol syndrome across the city, and we need to, you know, respond to that in a robust way with addressing all of the factors that lie underneath that. So I just emphasize that that there is that broader range of programs that also sit alongside this work that we absolutely have to prioritize alongside the service transformation. But yeah, happy to have further conversations after the board on that. Thank you.
Thank you, Victoria. In our session, we also had a discussion about how diagnosis of conditions during pregnancy was found to be difficult by some mothers who, and Thelma was describing how perhaps the conditions weren't being picked up by GPs. and that may be because of the way that it was described and the ability to articulate, but also some quite clear symptoms that weren't picked up in their view on a recurrent basis of preeclampsia and things like that. So I don't know if anybody wants to pick that up in a moment, but I'm just going to bring in Alison Lowe, who wants to speak about the issue as well.
Yeah, so I was really pleased to see that one of the areas of priority is going to be peer support, because I think that the issue of Black mothers being 5 times more likely to die in childbirth is a huge issue that we should all be really angry about, actually. There's lots of nice talking, but we should be very angry about the fact that if you're Black, you're 5 times more likely to die, according to the UK Confidential Inquiry into Maternal Deaths. And one of the ways that we could address that is through peer support. Liz Wigley once commissioned a Best Start project, which my organisation co-delivered, which was focused on working with parents around their ability to parent, and over 100 kids were 0 to 2, and we saved 80 children potentially going into care as a result of that project. So peer support is hugely important, but also the training of medical staff about the particular and different needs of Black women in pregnancy, I think is a key area that we need to be identifying here and doing something about. And LTHT, really happy to see they're here, but there are lots of things that we could introduce into the training for midwives and for doctors on maternity wards, which I think would transform the experiences of Black parents. The other thing that's important is female genital mutilation. That massively impacts on people's ability to get pregnant, but also once they get pregnant, there are obviously additional factors. There is an NHS funded pilot at the moment and doing some brilliant work, and I wonder how the strategy is going to include women who have been subject to FGM, because there are lots and lots of people in Leeds as well as in the wider UK who have been subject to that and who experience different outcomes as a result of that. And also, I think it's important to understand that the issues for Black women are very significant. There are also issues for lesbian and bi women who I've got personal experience because my daughter is gay, and access to IVF for lesbian women is incredibly difficult, and there has been, I've got lived experience of different treatment for lesbian and bi women, which has not been the case for other women who were straight. So I think there are factors for lots of different protected characteristics, and we don't need to lose that.
Okay, thank you very much. So I think a bit of a feature of the discussion has been about bringing it in views and the experiences of a wide range of different experiences and needs. And if anyone wants to pick up those issues, that would be really good. I was also would like to echo the comments made about how this is a great example of integration. You know, one of our primary functions as a board is to further integrate everything we do. That is a journey which never ends. I think it's a tough ask to keep integrating in what we do. But if I'd just like to say thank you to everyone for the work that they've done to really integrate this work, because it's right, absolutely, we need to get to every part of our communities and every setting in which people need support around maternity, and that is a whole range of places. So thank you for that. I think I've got Hannah who wants to come in as well.
Yeah,
Hannah?
thanks. Yeah, thank you. Just, and I don't know if it's part of the strategy but it would just be good to play in and sort of ask the question around how services are adapting in light of COVID. We've had some feedback, not a lot of feedback, but some feedback about people's experiences and the impact it's having on them, and not having follow-up consultations and not being seen face to face, or maybe getting the support they needed on breastfeeding, but that was earlier in the process. So I'm not sure if things are but I suppose it's the person we had the feedback was a first-time mum. It's a huge event. It's and to feel alone and isolated is not what we want. That's not the best start for the mum or the baby. So just something around the COVID response.
Okay. Now, I haven't got anyone else indicating. I know we need to agree some actions that I'll bring Tony in to talk about in a moment, but did Jane or Sue want to come in and just discuss respond to any of the points that have been raised and how that might be incorporated in our strategy going forward? And if I could also echo the praise about how the consultation on the changes to the maternity units went. I think it was a really, really excellent consultation. We were all very involved and engaged, and I'm really pleased that went through. So do you want to come in, Jane or Sue? And any GPs would like to respond to the issue around diagnosis during pregnancy for vulnerable groups, please indicate.
Shall I start, and then I'll pass to Sue in terms of the tremendous work they're doing to respond to COVID. So I suppose there's so many things here that I've got noted down. Absolutely, we had a really good conversation. I'm glad that John flagged up about the terminology, and Heather was suggesting diverse communities is a good terminology to use. I think that's really good. And kind of linked to that, to what John was saying about consultation. I mean, one of the reasons that scrutiny was so positive about the public consultation we did was we didn't just rely on a digital survey. We actually worked with third sector organisations to be able to reach into communities. I'm sure there's more we can do. And both in shaping the priorities and then the important thing about shaping how we deliver those priorities, that's when we really have to engage with people and co-produce. And we have to, one of the things Heather said in our group was work with the organisations that are trusted by the communities. And that's absolutely the way we have to do it. So that's our intention, and that cuts across all priorities. So it's a key principle that will cut across preparation for parenthood, personalisation, etc. It cuts across them all. In terms of the fetal alcohol syndrome, absolutely, there have been public health campaigns, etc., to raise awareness in the past, and we probably need to look at doing that again with our colleagues in public health. It's also probably worth knowing, it's recognised as, if Sue Rumbold was here, she would be flagging this. It's been recognised across West Yorkshire integrated care system as something that we need to do a piece of work on. And we have Leeds representatives in a working group exploring how we can identify and support more effectively this condition. In terms of integration, lots of the conversations that we're having is also being reflected in the refresh of the Best Start strategy as well. So the Best Start strategic plan, I was in a meeting the other day and we were having conversations about what we need to do across for our priority of getting the best possible start for babies. And they're also really looking at the strategic plan about how do we address health inequalities and really focusing in on that. So there is a real commitment, and we know we have to do better. And Heather also kind of mirrored something that Victoria said, which was about, this is beyond service. This is about how people are living in poverty, in poor housing, etc. So it has to be a broader partnership to create the best start for our children in Leeds. That's a kind of whistle-stop circuit of all things that were flagged. But I think in terms of a response to COVID, Sue's best placed to reply to that.
Yeah, thanks, Jane. Well, as everybody can appreciate, COVID's been challenging, but we still want to put the woman and her family at the heart of everything that we do. So it has been challenging, and from an inpatient experience, obviously we've got the challenges of the estate that we're working with, but that still shouldn't prevent us doing what we can to address the emotional need. A lot of this has been the perinatal mental health of women and their families in particular. So we have worked with our colleagues within the trust from an inpatient stay, and we have now got appointment-based visiting on the postnatal ward. There are constraints on the antenatal ward that is much more difficult, and obviously with local lockdown there are implications there, but we're working in full collaboration with IPC colleagues and estates, etc., to address that. One of the real areas that has caused a lot of concern, not at the beginning of COVID, but in recent weeks, has been the scanning issue. And again, we're working with our radiology colleagues on addressing that, particularly when it's such a unique experience, isn't it, pregnancy? And it's such a precious experience that if we don't get things as okay as we possibly can, the impact later on throughout the family, the next 1,000 days and onwards, we're going to be living with this potentially for years and years and years. So we've got to work really hard at recognising everybody's needs. But again, remember, the woman is at the heart of what we do. So we do have partners coming in for scans now, for dating scans, for 20-week anomaly scans, where we examine the baby to make sure there's no problems, and in early pregnancy as well. I think that we are trying to get back to normal in postnatal care with our community midwifery services. So we're still doing a lot using the digital platforms. But again, the face-to-face is really important. So again, we are now beginning to we're back in services, and we are doing face-to-face bookings alongside still some virtual appointments. But we're trying to get much more that person-to-person appointments, that risk assessment in place, as opposed to what we were doing before. And I think it's such an evolving field that we have to demonstrate flexibility and responsiveness at all times in order to deliver what we can, again, for the family and the woman. Just a point about what Alison was saying about Black mothers. Not only the embrace reports, the COVID, the response, and our families from the BAME backgrounds. I would really welcome working with you, Alison, about what you were saying about training for midwives, for doctors, etc. Because we've got to look at some things with the pandemic as a real opportunity for improvement, and that is definitely one. And if we just look at vitamin D, that's an easy one to start off with. So very much would welcome working with you regarding that. So again, I'm really aware of time, Councillor Charlwood, so I'll wrap up, but I'm more than happy to take any comments and anything, from anybody later on.
Thank you very much. I think it's really reassuring for us all to hear just how wide-ranging and the scope is of your thinking, and that just shows our Leeds approach, that it's shared with the NHS as well as the council, about organisations that are trusted and work with the communities, and our minority ethnic communities also include our Gypsy and Traveller communities as well. A very specialist group of people, and people are very different, have very different needs and vulnerabilities, no matter what their background. So thank you for all your work around that. I'm going to bring in Tony, if you can take us through the three things we need to agree, the actions, and then we'll agree the recommendations. Thank you.
Yeah, absolutely. So one of the things we've been asking all report authors is to be really clear about what the ask is, and to identify any tricky issues and any support that they might want from other bits of the system. So we've got three that Jane and Sue have identified. The first one is a task to the Estates Programme Board, and it's following on from the centralisation of hospital maternity services. There's a need for help in identifying appropriate estate to progress the development of the first integrated maternity community hub in Hare Hills, and also help in identifying any transport issues to get to the new hospital. So one key one there for the Estates Board. There's one also to the Workforce Board, the City Workforce Board, and it links to the earlier conversation actually really well, which is the opportunity to develop a workforce that represents all our communities. And one of the things that's in paper is expanding the doula model of volunteers, and in particular the recruitment of support workers from diverse communities. And then finally, and I'm not sure if Thea can hear this, but there's a task to her as the Senior Responsible Officer for local care partnerships, to explore with the maternity board the ability to identify and recognise opportunities locally for integrating LCPs Best Start and early help hubs. So some really key actions there that we need to agree.
Councillor Galton's just asked where this is in the agenda item on the page and the paragraph. This bit about agreeing these actions, are they dotted around in the report?
Yeah, they are indeed. I don't know if Arthur can
They're not in recommendations. Recommendations are separate, aren't they? Yeah.
Yeah. Right.
So Tony, do you want people just to nod and agree to those, or do you need any particular input?
Yeah, just to agree to take those 3 things forward, really.
Okay, I can't see anyone disagreeing. If you want to say anything about that, pop it in the chat. I think these are just actions that have flown from the report, Councillor Galton.
Yeah, that's right.
And if we can now agree the recommendations. Okay, take your point. Thank you, Councillor Galton. If we can have anything that needs to be agreed in recommendations, I think that helps people to be prepared for the discussions. Okay, are we happy to approve the recommendations? Thank you very much. Thank you for that item. It was a really excellent piece of work. And again, Sarah is saying she's already taking forward whole system approach to recruiting support workers. That's great, and you'll feed that through. Yeah, thank you for all your work on this. It's a really important area of work for mums and families and children right across the city. Really appreciate that. Thank you very much. Thank you again to those who came with personal stories. If you're watching on YouTube, thank you very much for your time again. That's very, very, very valuable. Okay, so without any further comments on that, we're going to move on to item 10, which is our going further with integration item. So this is about so when we share screens, I can't see my, this is about our progress as a city and the contribution of the NHS. Leeds CCG shaping our future programme. So can everyone still hear me okay? I've just had a few different screens pop up all at once. There we go. Thank you. Right, so without further ado, I think I need to just hand over to Kath and Tim. Kath is our Director of Adults and Health, and Tim Riley is the Chief Executive of the CCG. And we're talking about how we can push forward together, as is always our intention, to be more integrated in how we do things, how we deliver our services, how we commission our services, and how we tackle health inequalities, as we've already described in the previous item, at the heart of everything we do. Can I hand over to Kath and Tim at this stage? And I believe we have a presentation as well.
Thank you, Councillor Charlwood. I'm going to make some introductory remarks. So I think everyone will be aware that the direction of travel for health and care services is that of developing an integrated care system. But what does that mean in reality? So I like to think about it as it's a bit like baking a cake. There are some core ingredients, but each place has to write its own recipe. And what we're going to hear in the next few minutes in the two presentations is some insight on what those core ingredients might be. So in a minute, we'll be hearing from Tim Riley, Chief Exec of Leeds CCG, and Tim's going to talk about how commissioning is developing in the city. Then we're going to hear from Sam Jones from Operose Health, who will be sharing international learning from a provider perspective. But actually the reality is, I think our future, the distinction between commissioner and provider is going to become more blurred, because actually our future is about collaboration and partnership. However, the starting point is always the individual, and we're using the National Voices definition of integrated care as our lodestar, and you can see that on the screen now. So this is how we test, have we achieved integrated care? So can an individual say, I can plan my care with the people who work together to understand me and my carers, allow me control and bring together services to achieve the outcomes important to me? And we're going to keep that close to our hearts in how we take things forward in Leeds. So those are my opening remarks. I'll now hand over to Tim, who's going to take us through where we are with commissioning.
Thanks, Kath. Gina's going to contribute as well, I think, as we go through this. So I guess just an introductory comment for me before I hand to Gina. And I think it builds on what Kath has just said, that this is really important, that as a city, we're looking much more to build on our collaborative approaches. A lot of what's been done around commissioning, particularly in the NHS over the last 20 years, has been predicated on an internal market approach, a focus on services, activity and contracts. And what we're wanting to do is move away from that to a collaborative approach, an approach where commissioning is more around the population and understanding the population across the city and having a population health view, much more focused on the outcomes that that population delivers, and much less focused on competition and market, and a greater sense of commissioning supporting providers and other partners to work in a very integrated way. We've heard a bit about that around the maternity. We've seen other really good examples here at the Health and Wellbeing Board around things, for example, rather than just pursuing a very IAPT, service-orientated IAPT, how through commissioning and working again as a city, we've been able to develop a much more partnership-based approach and a broader sense of mental health and mental wellbeing service. So those are just some examples of where we're heading. And what we've done as a CCG is said, well, we came together from 3 to 1, but we could easily have just stayed as one very large version of what we were before. But we recognise that if we are going to support that greater integration journey as a CCG, we need to make some significant changes. I think it's also fair to say we've been trying to be and brought this work that we've been doing into the sort of spotlight a number of times. And this is a journey we're on as a city. We aren't starting to collaborate. We aren't starting to integrate. We've done an awful lot already. And this is actually about, if you like, accelerating some of that. I'm going to hand over, I think, to Gina now, if that's okay, Gina. And you're going to take us through the first few, and then I'll finish off nearer the end.
Thanks, Tim. Thank you. Yeah, but just in terms of sort of describing and talking about the Shaping Our Future programme and how it contributes to our overall ambition as a city, we thought it was helpful just to start off with the NHS Leeds strategy and the commitments that we've made in that, and really recognising the fact that the vision and ambition for the CCG is that of the health and wellbeing strategy, and absolutely Shaping Our Future and our overall strategy is about contributing to the achievement of that vision, both in terms of our unique contribution and how we use resources to deliver better outcomes for people's health and wellbeing and reduce health inequalities, but also in our role as a partner, as part of the broader partnership, and our role in supporting partners and people within Leeds to really support a greater focus on prevention and the wider determinants of health, working with people to increase their confidence to manage their own health and wellbeing, delivering more integrated care for populations in Leeds, and really creating the conditions that enable health and care needs to be addressed around local neighbourhoods and local care partnerships. And I think just reflecting back on the really powerful sort of definition of person-centred integrated care that Kath just referred to, delivering better outcomes, working with people and living more integrated care can be seen as, really aligning with that overall ambition. Next slide, please, Arfan. I think from the outset, it's really important to be clear about why we've embarked on the Shaping Our Future journey as a CCG. And as we set out in the background paper, and it's been really clear from the conversations already this morning, we have a strong foundation and experience of collaboration and partnership working, and also progress towards some person-centred integration. And we gave examples in the background paper. However, whilst we have made some improvements, we know that people living in neighbourhoods with the greatest socio-economic challenges continue to have poorer health outcomes. And again, that's come across really, really strongly from the early conversation today. We're also aware that whilst we have some really good examples of person-centred integrated care across the city, and I think the example of the way in which partners, in terms of both commissioners and providers of children's services, have worked together to have a really clear, focused set of obsessions with the voice of the child central to that, and supporting more integrated models of care between education, health, social care and third sector. although we do have some of those really good examples, we know that too often people receive fragmented care, which leads to a poor experience of care. And we also know that we're often too reactive and trying to solve the problems in the here and now, as opposed to looking in terms of a much longer term approach, in terms of planning and delivering in terms of the long-term needs of our populations. And I think as a CCG, we recognise that the way in which we've operated and indeed commissioned services, not unlike all CCGs nationally, and can actually make it harder to address these issues as a system and really achieve our ambition. And we recognise that we need to change the way we operate, commission and also facilitate change across the broader health and care system in a way that really enables providers to make it more easy for them to work together around integrated care, but also in a way that enables to be a lot more strategic, proactive and forward thinking, and focusing on the health of the whole population and their long-term needs, with a much greater focus on prevention and the wider determinants of health and well-being. Next slide, please, Arfan. So in recognition of our need to change the way we operate and facilitate and commission more person-centred integrated care, we established the Shaping Our Future programme in December 19. And the purpose of the programme is very much to design and implement a new way of working as a CCG, a new operating model to really enable us to consistently commission and facilitate change in this way that really incentivises person-centred integration. And a key part of Shaping Our Future is around strengthening our capability as a city to really develop a strong and vibrant health and social care system, which is able to take a much longer term approach to population health planning or strategic commissioning, and also enables a system integration approach whereby providers and partners are enabled and facilitated through different ways of approaching pathways and building some key infrastructure across the city and new ways of working to deliver person-centred integrated care. And we recognise that a key building block of that is actually supporting the design and delivery of care with people at locality level through local care partnerships, and really thinking about greater integration in terms of health and social care, physical and mental health, and specialist and generalist provision as well. And that integrated care wrapping around what matters most to a person, again going back to that definition that we talked about at the start of the presentation. The approach very much builds on our track record of partnership working. And I think it's important to also say that alongside the Shaping Our Future programme, we've also been undertaking some very specific work as a CCG through our Health and Equalities Framework, which again is around our contribution as a CCG towards tackling some very specific issues in relation to reducing health inequalities across the city. So just before handing over to Tim, I think it's important to be clear that, sorry, next slide please, Arfan. I think it's important to be clear that although the focus of our Shaping Our Future programme and specifically the operating model is really about how the CCG needs to operate differently, the overarching sort of ambition is that by operating differently and by doing this, we create the conditions to enable the broader health and care system to deliver person-centred integrated care and in turn improve population outcomes and reduce health inequalities. And it's therefore been really important throughout the Shaping Our Future process for us to co-produce and engage with our partners and providers across the city to really ensure that the direction of travel aligns with the broader developments happening and the conversations happening between partners and providers, again, around more integrated care provision and networks, and also in terms of how we move towards more integrated commissioning as well through the integrated commissioning framework, which we'll talk about later on. I think also to say that the approach within Shaping Our Future and the operating model is absolutely underpinned by a population health management approach, whereby we use data, and Leeds has got a fantastic asset in having a really good integrated data set to really identify and understand the needs of our population across the city. Really analyse and understand where the biggest opportunities are to improve population outcomes across our population, and then support teams of professionals, experts and people working at locality level and citywide level to really design and deliver solutions to really improve those outcomes as well. We're aware that to really move forward and as Tim said, accelerate this new way of working set out through Shaping Our Future and the new operating model, we need to develop new capabilities and new behaviours, both within the CCG and across the broader city as well. And I'm going to hand over to Tim now just to talk through that in a bit more detail. I think you're on mute, Tim.
Thanks, Gina. Yes, next slide. So just in terms of a little bit about when we talk about a new operating model, it's technical language in some ways. And I think Gina has emphasised the importance of us playing our part in the city. Now, if we do this on our own, that's rather pointless. This is something we are absolutely doing with partners across the city, shaping what we do, both partners in terms of commissioning and with Kath and colleagues and Victoria and Public Health and Social Care, but also more widely, but then also with provider colleague partners as well, about making sure that we're creating, as Gina said, the right environment. What we've looked at is how do we strengthen, create two capabilities. So rather than thinking about commissioners and providers, recognising that as a city to work in a really integrated way, there are a number of capabilities we need. And the two that perhaps the CCG has responsibility for and some expectation, but are quite different from perhaps how we've worked in the past, as Gina has said, are these two capabilities: a strategic commissioning capability, which is very much on setting strategy and outcomes, developing those long-term outcomes and ambitions that we want to achieve, but driven by the data and the information that we have, so that we are aware of both the challenges that are coming down the road and we can get onto that more proactive footing as a system, as a place, in terms of what we need to do and what we need to address. So that's one part of it, and that's always been to some extent a role of a CCG and a commissioner, but I think we want to play that role much more as part of a partnership and really strengthen it. The other areas around the system integration capability, and quite often, as I said at the beginning, we actually have a system that has to date been about producing contracts, creating competition, and actually very focused on service and numbers and activity. And what we're doing when we talk about integration is moving away from that to much more integrated models of care, right through from prevention to the specialist end. And we can perhaps talk about that a little bit later and what that involves, with a real focus on the outcomes that people achieve rather than counting the numbers of people going through services. And also, in order to do that, what we've discovered when we look at sort of international best practice and so on, there's a whole set of technical infrastructure and cultural change that needs to be done. And we're wanting to put other resources that we have as a CCG at the disposal of the city to support that to develop faster. So very much an enabling function to support some of that. So next slide, please, Hannah. Thank you. So what we've recognised we need to do is it requires new behaviours and capabilities among our teams. We have an approach that's been embedded. I've been a commissioner for 20 years in a world of market challenge. And I know that requires a change. It requires a change in both the way we think about the world, the way we respond to that, but also in terms of the capabilities that we have to support greater integration, more predictive and proactive planning. And in that sense, it's very much, as it says here, a symbiotic relationship with the work being done among providers in Leeds. And I do think it's really exciting. I love coming to work in Leeds because it's a collaborative city. And we want to build on that. I never go into meetings with my colleague chief execs of the provider world with a sense of dread or anxiety. And I have to say, having worked elsewhere in England, that is not always the case at all. And it's quite a powerful thing. And we know that provider colleagues are already working in a number of partnership type relationships, whether it's the GP Confederation with Leeds LCH, whether it's work between Sarah and Julian around how support people with both mental and physical health that need acute care. There's work between LCH and the LTHT around, say, the stroke rehabilitation work that's being done. So all those bits that are happening are things that we want to build on, and rather than commissioning being a block to that, commissioning being a support to accelerate some of that further. And it's also really important that we work very closely with council colleagues, as I mentioned already. So we have an integrated commissioning framework, which is in those areas of shared ambition, shared responsibility in places like mental health and some of our older population, learning disabilities and so on, that we actually have an integrated commissioning framework, and Kath may well want to comment a little bit more on that. The other thing I've just mentioned is this is very much about the national direction of travel for CCGs. I'm not sure CCGs will exist, who knows, post-legislative changes that are due next year. But what I do know is those strategic capabilities are important for every city. And what we're looking to do is to work through a city-based approach to make sure that those are embedded, whatever the future national changes to legislation are. And I think quite powerfully, we also want to make sure, sorry, let's go to the next slide. Thank you. Sorry, so just before I introduce Sam, the only other bit I would just say, picking up a comment at the side there, one of the things we're wanting to do, and why the GP Confederation in particular is a really important partner in the work that we're doing, is around the development, and the councils, around the development of local care partnerships. Actually, they become a place where a lot of the decisions are made. So when we talk about population health management, population health, what we've actually done is we've been part of a national pilot, and we've created data sets that have now been taken on by the LCP development team to really support people working in local places to address some of the challenges of health. And when we talk about health inequalities work, what we're wanting to do is make sure that we steer that resource to the people closest to the communities where that inequality shows up. And that's part of our approach and part of the health inequalities framework that we've sent around previously. So I'm sure we'll talk a little bit more about that, and there'll be questions coming. So I'm now going to pass on to Sam. I just should probably introduce Sam a little bit before she speaks. One of the things we've been really keen to do as a city is to look around the world at where some of these things work even better than they do in Leeds. I think it's hard. I always find the balance between being really proud of Leeds and the work we already do. The maternity work that we saw earlier is a good example. Lots of things that we can be very proud of as a city. The atmosphere, the sets of relationships are brilliant. And those are things I boast about. At the same time as being very proud of Leeds, there's something about have a degree of humility and to say, well, if we're good, how can we be even better? And what we've wanted to do and been in the process of doing is looking at models from around the world. So I know colleagues at LTHT and certainly us in the CCG have been, for example, look at the Montefiore system and the work the King's Fund have done on describing that. I'm talking to Staten Island as well, which is another part of New York, which has a very similar model shortly. We've certainly learned from some of the work done in Canterbury, for example. And then one of the other really good places that we're all aware of, and a number of us have had contact with in the past, is in Valencia. And so in doing that, what we wanted to do is to say, how can we learn, how can we garner support from some of those systems to help us on our journey from being the good position we are to being an even better position in terms of our population outcomes. And Sam represents Operates Health, which is very integral to the Valencia system, among many others, as Sam will touch on. But what we've asked her to do is really focus from their experience on what some of the key aspects of a really successful integrated health and care system might be. So with that, Sam, I'm going to hand over to you. Is that okay?
Thank you very much. Yeah, thank you. And thank you for inviting me today and for your warm welcome. I have a long career in healthcare in this country. It's about 31 years, I think. I'm a nurse by background. I'm a hospital chief executive by background, and more latterly I led the New Models of Care programme nationally, where we were prototyping the new models of care for the healthcare system. And I start with that because it's important that when we talk about integration, many of us have been thinking about it as the holy grail for a very, very long time. And it's always useful to remember that it doesn't matter whether you look at international systems, whether you look at systems in other parts of the country. What is the most important is the local community and getting it right for the local population, because context is everything. So there are some enablers which I will talk through, but the local relationships and the local context are the most important. I do have a number of slides, but I promise to try not to do death by PowerPoint, and I'll flip over some of them, but obviously leave them with you as well. Next slide, please. we keep going, thank you. So just a brief moment on what is Operos Health. So we support and enable integrated care in the UK. So we have four main approaches to it, of which you can see 3 on screen. The fourth one, first of all, is by delivering strong primary care, because primary care is where population health management starts. I don't just mean general practice, I mean population health in terms of the local communities and providing the care for the local population. Supporting and designing a system around individual patients. And I'll come back to this in a second, because I know we talk about this a lot. And again, in terms of the Holy Grail, but to give some very practical examples about what does that mean. Using our technology and expertise that we can leverage from our international partners, both across in the terms of the US and also in Spain, as referred to by Tim, and supporting partnerships at a local and a national level in terms of how to do integration in practice. So we all have an aspiration around it, but what does it actually mean and how do we actually do it? Next slide, please. So I was delighted to hear Gina describe the approach that's been taken in Leeds, and certainly from my national work recently, and also again with Operos Health. Of course it needs to start with the individual, the citizen at the centre of their care. Now, if I give you a personal story, at the back end of last year, I was very lucky and privileged to spend time with my godmother, who was diagnosed and subsequently died with motor neuron disease. For those of you that have had contact with it, it's pretty horrible. So I'd gone from leading the national work to being a care coordinator for somebody at the end of life. And despite the fact that every single professional did their absolute best to support her at the end of life, they couldn't communicate because the systems were different. There was duplication. People were asking the same conversation time and time again. Her husband was disconnected in terms of local community support, because it was very much a health-driven approach to end of life. It wasn't around this care and support in the community. And certainly in terms of the relationship between the local authority and healthcare was very disjointed. Now, that is not because the intent wasn't right, and it is not because people weren't trying hard. It's just that every system is perfectly designed. So what we've tried to do here is show, actually, as we all know, that the care of an individual, the citizen in the middle, requires us all to be joined up. It doesn't matter what part of the system we're in, we all have some kind of contact with an individual part of the system. And for us, fundamentally, the model of care is about delivering that in the least fragmented way, the most supported, with the individual in the middle. Next slide, please. And the one after that. So integration, the right intent alone doesn't make things happen. We absolutely know that. We've been trying for a very long time to make this happen, but we know that you need enabling support functions and tools to make it happen in practice. Whether you look at a network system such as they have in the US around a clearly defined integrator with a provider network, and then the integrator holds the risk, whether you take the Montefiore system that Tim described, which is built around local populations. All of these models are all about the local population, but again, an integrator holds the risk and it's all outcome based. Or whether you go to a fully integrated system in the way that Ribera Salud have in Spain, which is that it's a fully integrated, it's a capitated based system, and the organisation takes the risk. And I'll talk a little bit more about that. But the important point here is that an integrated care system needs to be supported, it needs the enablers, it needs to be networked, and it absolutely needs to be looking at the single source of truth, the same data, the same outcomes, to be defined locally, with then an integrator function sharing that risk. Next slide, please. So we all talk about population health. We all have fads, don't we? We go through phases around different types of things. But at the heart, population health management is about understanding the population, with them involved, and designing the care plan in a multi-agency, multidisciplinary team way, adjusting the risk and then doing something about it. It's quite simple when you say it like that, but actually being able to do it. And that doesn't mean health in terms of the community services or the hospital or primary care or the local authority or social care, community services, local community services having different types of approaches. It means that it's completely joined up, and that you look at the individual as a whole, and their care is provided on the basis of the risk to them as an individual, and it's personalised. Next slide, please. So the Ribera Salud model in Spain, and one of the benefits of COVID is enabling us to communicate so virtually so well, but one of the downsides is that you don't get to go and see places in reality. And I would very much have liked to have seen you today in Leeds, as opposed to in Buckinghamshire, so hopefully at some stage one day. But I hope you'll be able to experience some of the taste of Ribera Salud here today. So over the last 20 years, Valencia they started in Valencia, they've taken an approach which is the citizen in the middle, all about the citizen, not the patient. Absolutely notice it's about the citizen, supported by a sound clinical management strategy, as you would imagine, with a modern workforce approach, which is digitally based, enhanced, cross-functional information system. There are some consistencies in all of these types of systems, and again with the citizen at the heart. They call it the triangle of success, with the citizen in the middle, and it's the combination of those approaches that make the difference. It's not the tech, it's not the data, it's not the workforce, it's not the clinical management, it's not the approach to personalised medicine, it's the things coming together in what they describe the triangle of success. And if you think about it as a quality improvement programme, it is exactly that, with the citizen in the middle. Next slide, please. So what this means is using the data that has been described. So they have a data set for their population. Now, usually when I talk about this, people go, yes, but that's not where we are. And I always say, but Ribera Salud started with an Excel spreadsheet. They started with an Excel spreadsheet, and they have been able to, using the Johns Hopkins scale of disease classification, identify those individuals who are most at risk in their local system if action is not taken. They're the top of the triangle that you can see there. But also they're able to understand the cost per patient, and they're able to see actually on a daily basis what is happening to that individual, and also to the care that is provided and the outcome of that care with the individual. So it's both value for the system, but also value to the individual. Next slide, please. And what that means is, as you will have seen in many places, that you are able to then risk stratify. So it is, you apportion the care with that individual depending on the level of risk and depending on what is best for them. And I'll come to talk about this in a little bit more detail. But the thing to know about Ribera Salud is that it's a primary care-led system. So it's the hospital, but it's a primary care-led system. So it's a primary care-led hospital. So therefore, the care starts with the citizen right at the front, is coordinated, it is digitally enhanced. So I'll talk about that in a bit more detail in a second. And then it is, wherever possible, done in collaboration across the multi-agency teams working together. And then depending on the level, it depends on where that care is actually delivered. Next slide, please. So what they do is they take all of the data, they take the population health data that we've described, the single source of truth, and they identify those individuals most at risk of readmission if things are not done differently. Now, it is not being done to, it is being done with the citizen and with the family, and every inpatient receives a readmission risk score, which is updated daily, and really importantly, includes those professionals outside of the hospital. So they're already planning what will happen to prevent those individuals coming back. Next slide, please. And importantly, it's using the technology to manage and coordinate the population health needs. So they have a portal. Similar to many of the things that we're starting to see, and certainly been accelerated through COVID. So Citizen Portal, they have everything on their phone. They are able to access anything that they need 24 hours a day to the healthcare professional. They've got their results. Can you imagine 24 hours a day? You just need to, it's like phoning First Direct. You need to pay your bank. I just need to check what's going on with my care. And interestingly, they haven't been overwhelmed, which is one of the first things that come back. They have all of their public health advice, their public health support. They're able to get their results, all the pharmacy is done. So, you know, the self-care aspect of it is a very important part of population health management. And then, of course, as you can see, moving up the triangle, I think that is actually showing where individual parts of the system come to play. So primary care networks working together using health coaching, for example, and then moving up the risk score, making sure the whole purpose behind this is to keep as many people at home, as close to home as they possibly can, but that the care is accessible as opposed to them having to come in for the care. Next slide, please. And why is this important? Because what we know in Ribera Salud, and you will see this replicated in any type of integrated care system, whether it's in Spain, whether it's in the US, whether it's in Canterbury, you will see very similar that 27% of the patients, 27% of citizens in a system account for 72% of the cost. And that's the financial cost to the system. That's not the cost to the individual. So of course, if you target the care, and we certainly saw this through the national work here in the UK, if you target the care, you wrap the care around that individual and their carers themselves, you are then able to influence what happens to them, creating additional capacity and support for those people to prevent them moving up the care spectrum. Next slide, please. So just to break this down a little bit, what's important is when, from a clinical management perspective, it's making sure it's standardized and it's working in accordance with best practice. Now, we all have care plans, we all have different types of plans. Actually, how do we know what really goes on a daily basis, and how do we know that that those individual practitioners are working across a multidisciplinary team? So how they've done it in Ribera Salud is that they've created these clinical practice guidelines, as they call them, across a multidisciplinary, multi-agency team. And then they're adhered to, and they know how they're adhered to because they track them, because they have the system to be able to track, to see what happened to, let's say, Tim. If Tim came into or needed something happening, they could look back last week and say, okay, Dr. Jones, this is what happened. Why did you take that action? Now, it's not being done outside of clinical expertise. It's being done because these individuals, the clinicians, the patients, the carers, the practitioners, the pharmacists, etc., have all designed these decision support tools. So it's working to the best practice, but what it's absolutely doing is reducing variation. And reducing variation, we know, is one of the biggest opportunities. That's not about just cost, but it's reducing variation of care in terms of the individual experiencing it. Next slide, please. And we did some work in Nottingham last year, and what you can actually see is, depending on the individual care worker, so depending on who you interact in a care team, there is significant variation depending on which individual delivers that care. Now, we sort of know that, but what we've been able to see here, and you can see, is that the chances of going into ongoing care range from 1 in 20 to 1 in 4, depending on who was delivering that care. Now, that's not to say the individual who's delivering that care is not doing their best, because they absolutely are. But if they're not working to a care pathway that's been agreed across the system, and they're not supported, and they're not, information isn't fed back to them, and they're professionally developed to understand the implications of what they're doing, they won't change. So when I referred back to a quality improvement approach, that's what I mean. So reducing variation, and you will certainly know this from the work with Virginia Mason, reducing variation is so important in terms of regular feedback so the individual practitioner knows what's going on, and there is the data available to be able to support that. Moving on, please, to the next slide. So what does this really like? That's all very interesting, Sam, and there's some great management slides there, but what does this actually mean to an individual who's experiencing it? So what we tried to show here is Jim's story. So if you start on the left, so patient portal, as I say, Jim is able to access his care plan. He's able to interact with care professionals. He's got his results, he's got his information, he can say how he's feeling, and he can contact the care team if he has any concerns. Now, what happens there is that Jim is part of a segmented system. He doesn't know he is, it doesn't make any difference to him, but what we've done as a system is look at the population needs, and we've been able to segment them. So we know he's got multiple long-term conditions, including heart failure and diabetes. So there's a dedicated multi-agency, multidisciplinary care plan for him, of which he is involved in the discussion around his care plan, and that the workflow management that is then put together is based on his care plan. So everybody can see, irrespective of where they sit in the healthcare system, everybody can see what it is that is required to manage his care appropriately. And that requires that join up into how many times have you spoken to people who go, I have to tell my story 400 times, I have my results repeated 100 times, except if my blood's done. This is to, the workflow management, as it's called, is to prevent that happening so that everybody can see and everybody's coordinating. And if I take you back to the story of my godmother, their care plan would be something that everybody could see, with permission, all the appropriate safeguards, but there is one single version of the truth. And then on the far right, you can see Jim, his care plan is delivered, he's kept in contact, and he's able to access, and we can see real time with what's going on and what is the impact for Jim, and then it can be adjusted as needs be. Moving on to the next slide, please. So it's just showing you some of the outcomes from Ribera Salud perspective before they started population health management, and then after, in terms of, so you can see there the impact itself. And this is independently audited, it's published, you can look in the Harvard Business Review, you can, the individual audits which I can share with you. But what is absolutely clear is that they have reduced the A&E attendances, they've absolutely reduced outpatient appointments, not because people don't necessarily need care, but it's how that care is provided. Their length of stay has reduced and their readmissions have reduced. And this isn't just as a snapshot, this has been ongoing for years, and very happy to share more of the audits if people would be interested. So moving on to the next slide. So irrespective of which system you look at, whether it's in this country, whether it's in Nottingham, or whether it be in Leeds or in Northumbria, you will, there are very similar types of enablers that need to be in place. And I bet if we did a look at Leeds at the moment, you'd see many of these types of functions already being performed. And in one part of the country that we work with, there were over 40 integrated discharge teams, all working in different parts of the system, none of whom were actually integrated. So it's because of our silo working, because of the way that we've built our structures, but what we know is that there is a real opportunity to bring the system together and to focus some of the functions. So reducing duplication and absolutely maximising the chances of the people being able to work together. So next slide, please. So this I took from our national work. So what do you actually need to deliver an integrated system? I described here a multi-specialty community provider, but an integrated system. It doesn't just happen by intent, as I've talked about. Certainly you go, okay, now where do we start? Because it feels so big. well, we start like any other transformation program, which is there has to be a shared local vision. We took these themes from a lot of international work and a lot of the local work. So if you don't have a shared vision, there isn't any point in starting. So what's the shared vision, and who is actually driving and managing that transformation program? So when we all talk about integration, we go, yeah, it's the most important thing. We know this makes sense for us as individuals, it makes sense for the care that we want to provide, and then everybody goes back to the day job. So what is the engine room, as it was described, and how is that transformation program being managed, and how are decisions made? Do people really know how decisions are made? Is actually there a board that takes collective system responsibility and is able to move things? But do people know? So I'm not one for drawing lots of structures on a governance chart. That's important, but what's really important is that people know how those decisions are made and share that collective responsibility. And I'm not sure I've said this strongly enough, but people that have heard me talk before basically say I bang on about this. If there isn't a single source of truth, if you don't understand your population as a collective with that data, it won't happen. So when I was a hospital chief executive, I had my 3 times a day conference calls whilst we were trying to go through, when we were all under pressure, different types of alerts, and we'd all sit there and go, yeah, we're absolutely all the system leaders looking at the same bit of information, but actually we had our own separate lists. And we were looking at our own separate bits of data, because if we're not looking at the same thing, and if we don't understand collectively the needs and therefore the actions that need to be taken, we don't have a single source of truth. What's really important is to understand how and what are the interventions that are going to lead to the changes that are needed. Sometimes we don't know what they are, but the logic model associated with it means that you can actually track and you can stop doing things if it isn't making a difference to the individual, the people, the citizen of Leeds, and the transformation program itself. And again, the value proposition, the financial case. And I refer to this because people go, yeah, but we don't have any money. But if I went back a slide, which I won't, but if I went back a slide and said to you, how many of your functions are duplicated across Leeds? How much resource can you release by bringing things together? We'll be able to create the financial case associated with it. There's no question that we know when we have different parts of the system being able to design and document different parts of the care redesign around the local population, the LCPs, the voluntary sector, the community. We kind of know, and they certainly know, and those individuals who are delivering their care, and certainly the individuals who are citizens themselves who are both potentially going to receive care or are receiving care, they absolutely know what they need. So the care design isn't really the most important. But what it is bringing it all together and then making sure you plan, and you execute as you would do with any normal change program, and adapt. And I think there's one other bit at the bottom which I can't actually see, which is a good challenge for me. Bear with me whilst I just confirm the last one. And then, and only then, do you commission the new model. So if you've got all of these systems in place, you commission, but it's the commissioning at the end as opposed to starting at the beginning. So I'm going to leave you with one final slide, I hope. Go on. I haven't got the final slide. So the final slide is how it is applied locally for Leeds in terms of the enablers and moving things forward. And I'll stop.
Is that the conclusion of the presentation from the presenters, just to say?
Yes, it is.
Yeah, great. Can I just say that, is it Samantha or Sam? Sorry.
Either.
Oh, well, thank you for coming today, and I didn't get a chance to introduce you or welcome you, but I really appreciate your time and bringing us your insights and a really great level of understanding and experience from around the world as well. It's really, really valuable. We always want to learn and listen to what others are doing and see how we can use insight from elsewhere to enhance what we're doing and make it work for Leeds as well. I think that we have had a really good level of detail in those presentations, but I don't think we're going to do it justice if we try to make decisions today, because we simply won't have time, and from now till the end of the meeting really to chew it over. So at the beginning of the I will take some questions, but I'm just saying I think that we need to bring this to a workshop of the Health and Wellbeing Board, as we discussed at the beginning when Councillor Galton mentioned that we could do with a bit more discussion about this anyway, in terms of it not just being a one item and then we know what we're doing. It's such a big long-term piece of work that we need to really get to grips with it. So I'm going to suggest that. So I've got a number of people needing to leave the meeting, so I'm going to take that forward then as a thing we need to do. I do have a few people who want to speak. Got I think Councillor Galton's question was answered about LCPs during the presentation, and Councillor Galton saying the presentations are very useful and help to explain the issues much better than the paper did for lay people such as ourselves. Thank you. And Kath's also agreeing that it should be taken into a development session. I think so. I don't think we'll have enough. There's not enough time to go through it properly. I think I've got two people who want to ask a question: Alison Lowe and Councillor Harrington. So can I take Alison first?
Yes, thank you. It's not a question, it's a statement. So I just want to ensure that all conversations about commissioning at CCG level and across the piece take account of the ICS review into BAME experiences of health inequalities. There's a big deep dive being undertaken into commissioning. We've got lots to say, so I chair the VCS panel that shadows that group. We've got lots and lots to say about that. And I would also say that we need to co-produce in Leeds some commissioning principles with all our partners. It really mirrors in some way the new LCH third sector strategy, because we should have a third sector strategy across Leeds, across all statutory commissioning partners and providers, to talk about what's really important if we want to achieve better outcomes for all our communities. So please look for that piece of work. It's launching on the 22nd of October, and let's then include that in the next big piece of work that's going to take place.
Thank you very much. Can that be taken into our development session as well as part of the discussion? Yep, Councillor Harrington.
Thank you, Chair. It's just with my previous work life experiences, there's roughly 2,300 prisoners incarcerated in the Leeds city area. So you've got Leeds prison with 1,200 and odd, you've got Wealdstone with 800 and odd, and then you've got Wetherby YOI with a couple of hundred. And I'm just interested to know how we integrate prison healthcare into the broader community, because there's mental health issues as well as physical health issues. The fact that computers don't speak to each other, the fact that many of the prisoners have got mental health issues, but then you also have to remember that there are female prisoners incarcerated from Leeds, the Leeds citizens, sorry, in Wakefield and York. So that it's not just about people who are living in the city and you send somebody to prison, you forget all about them. So I think in the development group, I'd like to see some discussion on how prison healthcare is integrated as well. Thank you.
Thanks. Does anyone want to come back quickly on how prison healthcare is currently delivered? My understanding is is it an NHS England commissioned service and not something we directly do, as you say, local service. So, Tony.
Yeah, that's right. There are different bits to it. There's obviously the prison healthcare that did used to be delivered by a Leeds organisation, and then there's the care that's delivered also in custody suites. And one of the key issues is obviously prison discharge, and when prisoners, particularly short-stay prisoners, come back into Leeds, ensuring that they have primary care and mental health and substance misuse care. It is something we've looked at, obviously, and touched on in previous Health and Wellbeing Board sessions, but I do think it's a good idea maybe to open that up again, and I know Simon and colleagues in Safer Leeds will probably have to do as well.
Yep, and certainly something around I was going to say discharge, but release. It's certainly something we need to be integrated about, isn't it, with housing and support and healthcare as well, and social care in prisons. Kath is describing is commissioned by the local authority. Yeah, so that's something we should take forward as well into our discussions. So I have, and Dr. Beale saying good point. It is a very good point. Thank you for bringing that up. So I'm going to suggest at this point that we move this item into a development session and that we take further discussions there. And I'm going to sort of assume, therefore, we don't need to move the recommendations, but someone from governance might have a problem with that. So if anybody wants to suggest we have a governance issue if we don't take some recommendations through, I'm not hearing anything. That's okay. Yep, right, good. So we'll do that. Can we move on to item 11 then? So we described at the beginning of the, and thank you very much for everyone who, by the way, who presented on the item before. One of the things I wanted to say as well was that it was really great to hear from Tim that we are a really collaborative city and that we all work, the chief executives and the top directors and people leading, that are really collaborative in their experience compared to other areas they may have experienced, which is really wonderful to hear. And thank you to everyone for that, because it's only by building on that that we'll make any progress for our residents. So thank you. Continue the good work. Okay, so we said at the beginning of the meeting that we wouldn't really go into the detail of these papers, but they've come to the Health and Wellbeing Board before. This is their revised paper in final form, based on the comments that we made and the reflections that we made the last time they came. So unless anyone wants to mention anything about the Leeds Carers Partnership Strategy, and I'll just say that, you know, carers are absolutely vital in our city and the health and care system, and that the issues affecting carers have become manifold in recent months, since obviously dealing with COVID as well as everything else. So huge thanks to all the carers in the city and the unpaid carers who work to support their loved ones. Are we happy to move the recommendations? I can't see any comments. Happy to move the recommendations. Okay, thank you very much. If we move on to item 12, that's the Living in Dementia Strategy. Same applies. They came to the Health and Wellbeing Board, made amendments, and now in final draft. Anyone want to comment? Really important piece of work for our most vulnerable elderly residents in the city. I can't see any comments. I'm assuming you're happy to move the recommendations with those. Thank you. And if we go on to item 13, which is the Leeds Health and Care Climate Commitment. So we really welcome the leadership from the health and care system on this really key issue. We all need to contribute to climate change issues, and it's one of the pillars of our council's work, the climate emergency work. So can we approve and agree the recommendations in this report? Anyone want to comment? I could take a couple of comments if anyone wants to make anything, say anything specific. Tony, do you want to mention the question that we had from YouTube at this stage?
Yeah, absolutely. There's a question coming in, which is ultimately about the interaction between COVID and pollution and air quality, and a comment that obviously poor air quality and pollution may well exacerbate problems with the lungs and breathing, etc. So I think the action is maybe for Victoria to take that back to colleagues in public health, and we'll do a formal response outside the meeting.
Yeah, and I just thank those on YouTube for the question that you've asked, and also for watching and engaging with this session. And any more comments on that paper? Happy to read the recommendations. Yeah, great. And then we're on to the C papers, which is more formally, as we normally do, have items for noting. So I won't go through those individually, and just accept that we have noted those. And if we go on to item 18, which is any other business, would anyone like to raise any issues or concerns or any comments that they've not managed to have a chance to say during the meeting? Please raise it now. I'm not seeing any comments. So in that case, I think, Arfan, am I okay to conclude the meeting, unless you want to tell me that I've missed something?
Nope, everything okay.
Okay. Well, thank you very much, everyone, for what has been a really good meeting. We'll have discussions in the development session as well about format of these meetings and whether the way that we've worked it today needs tweaking even further. But huge thanks for all the work you're doing, and especially during these difficult times.